Thank you, Dr. Manish. It's always a pleasure to come back to Lucknow, where I did my DM. And this is the auditorium when it started. The first event which occurred here was the ISG Con of 2001, which was organized by Dr. Chaudhary, who's my teacher. Thank you, Dr. Dhiman and Amit, for inviting me. So I'll be talking about non-invasive diagnostic markers for NASH, and I would not go into too much of data and cutoffs and all that. I'll just give brief points of pros and cons of various modalities, and then I'll give you a brief algorithm. So what do you want to assess in a patient of NAFLD? So there are three things which we would like to assess, whether be it by biopsy or by non-invasive method, whether the patient has got steatosis and how much is the steatosis, whether are there inflammation, is there inflammation in the liver, and is there any fibrosis? So how do you define steatosis? Steatosis is defined according to the number of affected hepatocytes. So if less than 5% of hepatocytes affected by the fat, then there's no state or very minimal steatosis, or it is labeled as S0. 5 to 33 is S1, then more than 33 is S2, and more than 66 is S3. So having significant steatosis. So how do you assess for steatosis non-invasively? There are many modalities. Ultrasound, CAP is the controlled attenuation parameter, which is a part of FibroScan, then MRI, advanced MRI technique, and also CT scan. So coming to the ultrasound, which is the most commonly available modality everywhere, widely available, very cheap, I mean, compared to others. But it is not very sensitive, especially if the fat is less than 33%, especially the S1, then it is not very sensitive, and it is difficult to perform in patients who are severely obese. And always there's a subjective variation. Some people may mark it as grade 3 fatty liver, and some people may say it is grade 2. And so there's always a debate between the radiologists. So how do you grade based on the ultrasound? So grade 1 or the mild fatty liver, when there's increased echogenicity of the liver compared to spleen or the kidney. So when the liver is looking more bright, so then it is grade 1 compared to spleen and kidney. Grade 2, when there's a blurring of the intravascular structures like veins or vascular structure in the liver. And grade 3 is when there's deep attenuation of the ultrasound. That means even diaphragm cannot be properly discriminated from the liver. So, but this is definitely there's a lot of subjective variation between performance. Coming to the second modality, that is controlled attenuation parameter. It is something which is added to the FibroScan. Initially, FibroScan was measuring only the liver stiffness. But now they added something. This also measures the how the attenuation of the liver is there. And it is nowadays most FibroScan machine or the Fibro Touch machine would have it. It is more accurate than ultrasound for getting to know how much the fat the liver is. But the cons are that the cutoffs for variable grades of fat are very variable and are different in different studies. And the differentiation between S1, S2, and S3, I remember I told you what is S1, S2, S3. It is not very accurate. So it may be better to rule out and rule in rather than exactly differentiating. Then when the patient is already having diabetes, and then there's sex difference and BMI, also all these affect the values of CAP. And the cheaper version of the FibroScan, that is a Fibro Touch machine, which has got UAP or ultrasound attenuation parameter, it is even more unreliable. So according to various meta-analysis and some of the Indian studies, the various cutoff given for the CAP are mainly, if it is less than 248, then we can rule out any steatosis. But if it is more than 280 or 300, then the person has significant steatosis. Coming to the higher advanced technology, that is MRI-based fat estimation. It is called as MR proton density fat fraction. Nowadays, more and more studies are using this MR-based estimation. It is much more accurate than ultrasound and CAP. And even now, many trials conducted worldwide are using MR PDFF in place of liver biopsy, but it is very expensive and obviously not available everywhere. So when you, if you get a chance to see patients who have undergone MR PDFF, if the fat is higher, then you'll see more of yellow. If the fat is low, then you'll see more of blue. Coming to the CT liver attenuation index, it is widely done by the liver transplant surgeons. They look at the Hounsfield unit of the liver and then they compare with the spleen and they subtract it. Generally, when there's a lot of fat, it will look more of black or dark. So if it is if the Hounsfield unit is, the fat is actually -100. So if normally if there's no fat, then the liver to spleen difference is more than 5. But if there's fat is too much, if it is looking too much of black, then it is less than -10. So this is the cutoff. Only one cutoff you need to remember is less than -10. However, it is expensive and not very accurate for grading various levels of fat. And then obviously there's radiation exposure. So all these were for the steatosis. Now, how do we assess for liver inflammation? There are multiple modalities, but I'll only briefly mention about ALT/AST, which is common and everywhere. It is widely available, very cheap, but it may be normal even in presence of inflammation. So normal ALT does not rule out NASH or significant inflammation. And there is lab-to-lab variation of ALT values. And ALT is more specific for liver, but AST is even more non-specific. So there's been one study where they looked at people of non-alcoholic fatty liver disease who had raised ALT and who had normal ALT. And then they did their biopsy. So out of 100 patients who had raised ALT, at least 83% of them had inflammation. But of them who had normal ALT, even on biopsy, at least 60% of them had inflammation. So obviously, when the ALT is high, you would reasonably suspect that the patient definitely has inflammation. But even if it is normal, you cannot rule out. So with these caveats, now coming to the fibrosis, the third part, which is the most essential part, because most of the outcomes of the fatty liver depends on how much fibrosis the liver has. And there are various modalities to assess non-invasively fibrosis, the most important being FibroScan. So FibroScan is now available at most of the tertiary care centers, but and now we have vast experience using it, but obviously it is costly and it is unreliable if the patient already has jaundice or if he has some amount of infiltrative liver disease or liver failure. And it is difficult to perform in obesity, although there's an Excel Pro for them. But if the obesity is there and ascites is there, it may be difficult to perform. And various cutoffs have been given, but we need to remember only two values. One is 8.2. If the FibroScan value is more than 8.2, that means the patient has got significant fibrosis. If it is more than 13.6, that means he is having liver cirrhosis. But less than 8.2, then it is reasonable to say that the fibrosis is less. Coming to other modality, which is called as shear wave elastography. It is a certain addition to the ultrasound technology only, and it is done along with ultrasound only. But the cons are that it is operatable dependent, and when there's significant necroinflammatory activities going on, then the values of shear wave elastography may differ from patient to patient. And we have got less experience using shear wave as compared to the FibroScan. And there are many types of shear wave, like one is point shear wave elastography and 2D shear wave elastography. And there may be variable cutoffs for each of them. So it is difficult to remember all of them. So we have to depend on the reports, whatever is given. Coming to the MR elastography, again, it is very expensive and with very limited availability, but it is much more accurate because you get to actually scan the entire liver. So more and more research studies are being done, but on clinically in the clinic, it is very difficult to perform, and availability is also poor. What about the blood tests? So there are multiple blood tests. There are patented blood tests like fibro test and many others, which are mostly available in Western countries, not widely available in India. But simple blood tests which can be calculated using AST and platelet. There are various scores like APRI, FIB4, NFS, that is NFLD fibrosis score, and BARD. So all of them use mostly AST and platelet. Almost all of them use. And with FIB4, they also added ALT and age. With NFS, they've also added whether the person has diabetes or no. I'm not giving you any formula because all of them can be easily calculated in your mobile phone using any of the app like MedCal. Simple to calculate. Now we have good experience with APRI and FIB4, and FIB4 is now considered much better because many studies have shown its superiority. But again, it is not accurate for grading of fibrosis. So it is only good for ruling out and ruling in. So I'll just want you to remember only two numbers, one for APRI and one for FIB4. APRI, if it is more than 0.5, then the person may have significant fibrosis, and FIB4 more than 1.3. Remember only these two values to rule out significant fibrosis. So a very elegant algorithm has been given by the INASL guidelines, which was published recently by the stalwarts of NFLD, Dr. Ajay and Dr. SP Singh. And thank you, all of you, for giving me also an opportunity to be a part of this. So algorithm is there, but I have further simplified it for the benefit of residents. So how the patients will come? The patients will come to you with abnormal liver test, or so you would need to evaluate whether the patient is having fatty liver disease, or even if the LFT is the normal, but if the patient is obese or he's having diabetes or metabolic syndrome, we need to rule out whether he is having fatty liver disease. The third group of patients are those who already are carrying a report of fatty liver on their ultrasound. So in these group of patients, the first investigation obviously you'll do is ultrasound, and if fatty liver is detected, the first thing you'll do is rule out other causes of fatty liver. So what are the other causes of fatty liver? There, one of the most important being excessive alcohol. So just simple history taking, if the from the patient as well as from the family member, they can let you know whether alcohol is there. Apart from there are other causes also like hepatitis C, Wilson's, lipodystrophy, and even starvation, and the patients on parenteral nutrition may have. But obviously, from the clinical setting, you will know that this is not the case from of the patient. So once you have ruled out other causes of fatty liver disease, if you are sitting at the primary care level, just do do platelet count and the AST level to calculate FIB4 or APRI. Or if you are at the tertiary care center, then it's better to do a fibroscan. And then you'll have patients who have all of these are normal, that APRI is less than 0.5 and FIB4 is also normal, less than 1.3. And if you have done fibroscan, it is less than 8.2. Then these are patients who have very low risk of disease progression in terms of fatty liver. Obviously, patients may be having diabetes and obesity, so they may be having cardiovascular diseases, but at least for the liver point of view, the patient is pretty safe. But if any of these are abnormal, then these patients are at high risk of disease progression and they need further evaluation. I'm not going into detail how they should be managed, but obviously diet and lifestyle is the mainstay, and in whom you would give pharmacotherapy depends on their risk profile. So to take home points, if a patient has fatty liver disease, the most important point to look is whether can he progress to advanced liver disease or no, or does he have underlying advanced liver disease or no. And fibrosis is the most important predictor of progression. So most of the non-invasive tests actually try to pinpoint whether the patient has liver fibrosis. And the three most important tests are AST, platelet, and fibroscan in terms of non-invasive tests for fatty liver disease. And we should use more and more FIB4. It's available in your mobile apps. And it can also be used for disease monitoring as the patient, we give the treatment and he tries to lose weight, and then we can follow up him instead of doing fibroscan repeatedly. Thank you for your patience here.